lectureship is one of the most special lectureships here at UC Davis. Dr. Fry was one of the founding fathers of the Pancreas Club, and most well known for his the Fry procedure. There aren't very many of us in modern era who are still in the circumstance where they have a procedure named after them. So it really is a very special privilege to have Dr. Fry is among our distinguished faculty, and we're thrilled to be able to develop this lectureship in his name. Dr. Fry is in fact with us today in the hospital. He wished he could have been here, but he is actually experiencing some of the great care by our team for an illness, and in fact, but Charlie is well enough that he asked to have our professor visit him today. So we're really glad to be able to make that very special thing happen for Dr. Fry. And we are thrilled to have this opportunity to honor the work that he did. I'm going to turn over the introduction, our distinguished speaker, to Dr. Bold, and appreciate having you with us.
So it's a pleasure to have Chris Wolfgang as our Fry lecturer. Just a very quick background. Chris got his MD and his PhD in biochemistry from Temple, then went on to residency at Penn State, then the Hopkins Fellowship, and joined that powerhouse of pancreatic surgeons led under John Cameron, but many people that have been trained by Cameron, and names that you'll recognize including Tim Pollack, Rich Schulich, Keith Lillimo, Charlie Yo, and all those people are chairs of surgery across the country. We anticipate that probably is on Chris's future trajectory, given that enormity.
No thanks.
An author of over 400 papers, and he currently holds the John Cameron Professorship in Surgery at Johns Hopkins. Many other titles and accolades, internationally recognized for his experience in pancreatic cancer and pancreatic surgery. It's a tremendous honor and pleasure to have Chris Wolfgang as our visiting Fry lecturer.
Thank you. All right, let's see if we're turned on here.
Okay, well, thank you, Rick, for that wonderful introduction. You're very kind and greatly appreciated. If you're waiting for me to be the next chair, don't hold your breath. I'm pretty happy doing what I'm doing, and I know what I'm good at and what I'm not good at. My first observation of coming here is that it's really nice and enjoyable to come to M&M when you're not on the menu. It's actually, you don't get to see someone else's M&M very often. The other thing, this is a very big honor to me because I actually know Charlie Fry. Never trained under him, never had any formal work with him, collaborated with him. But from a very young age, I was always highly endeared to the Pancreas Club. It's just if you've never been there, but if you're interested in pancreas, it's probably one of the best meetings where on the stage you can have a medical student presenting some of their research, and then the very next presenter could be a Nobel laureate. And it's all one room, all plenary. And this was started by Charlie Fry and several others. And I remember when I was just a little nobody, now I'm a sort of a big nobody, but when I was a little nobody, I was sitting in the crowd, and Charlie Fry came up and talked to me, introduced himself. I was sitting next to John Cameron, and he struck up a conversation. The amazing thing is he never forgot my name, never. The other interesting thing is that, around the holidays, every Christmas, I get an email from Charlie Fry asking about me, asking about John Cameron. He's a remarkable human being. Nowadays, as Dr. Farmer pointed out, very few of us have operations named after us. In fact, actually, if you have a maneuver named after you nowadays, it's probably not a good thing. But, he's an incredible, incredible human being who really was a pioneer in his time, a master surgeon, a scholar, a mentor, a role model, and really a legend, but probably first and foremost a wonderful human being, and I wish him his best. This is really, truly one of my greatest honors to speak here. Now, is there any better job in the world than to be an academic surgeon? And I would say no. And this is part of the reason. We're all engaged in the same thing. Multiple hospitals, multiple programs, but you come and you see that things are very much the same. And we're engaged in patient care, whatever our specialties are. And you get to develop this small group of colleagues and kinship with people who they really become your family in the field. And actually, it's an honor also to be here because of these two individuals. Rick Bolt, who I really do not know personally very well, but obviously heard a lot about him and is really somebody who is a role model and leader in the field. And then Sepp Galami, who's sort of at the other end of that spectrum, but who I can tell you is one of the most intelligent, charismatic people that I know, and I guarantee you that she is going to be a leader in the field. And some of the revolution that we'll talk about, it'll be her and her generation that will lead it. Now, I never got to meet Dr. Ho before. I heard of him vaguely, but I got to meet him last night. And at dinner, and it was a wonderful thing, and I really appreciate you spending the time with me. It's nice to see that we have a lot in common. I think you're really a surgeon, an innovator, and it was wonderful to get to know you. Purvi Parikh, who I don't know if is here, is another sort of fixture in HPB surgery. I know not at UC Davis, but I think that the residents work with her somewhat, and she's at the VA hospital. And then, of course, you're under great leadership, and the department takes on the sort of persona of their leader, and you have a wonderful leader, and this is a wonderful place, and I really appreciate the invitation. So now, on to work. What am I going to do today? Well, I'm going to review the biology of pancreas cancer as it relates to surgical management. I'm not going to get too much into the weeds on the biology, but we can talk a little bit about it. And I like to tell stories. Now, one of the things that actually, if you work with John Cameron, you cannot get away from is the history. From little on up, it is constantly drilled in our heads. He quizzes us on it. He's always telling us stories. It's very enjoyable, and you wonder, well, what is the purpose of it? And as you get older, and now I'm a grandfather, you actually begin to see that actually history is important, because first of all, any good idea that you have has probably already been had, and somebody else has thought of it. That's the first thing. The other thing is that you'll see that things go in cycles. And what was old and out of vogue becomes new again, and we repeat these cycles. And sometimes these cycles may help us predict what the next revolution is going to be. And that is sort of the premise of this talk. And then I'm going to go out on a limb, and I'm going to predict what the next revolution is going to be. You can argue with me on that, and we'll find out maybe 20 years from now if I'm right or not. Now, here's the bottom line. Only 9% of patients with pancreas cancer at the time of diagnosis, if they're diagnosed today, will be alive in 5 years. Why is that? Well, let's just dissect this briefly. Surgical resection of clinically localized pancreatic cancer provides the only chance of a cure. Now, in and of itself is one of many modalities, but it is the only way. So now let's look at this in the case of evolution and revolution. So revolution is a dramatic change in the way that we do something, or a dramatic takeover of what is the standard. And evolution is a general creep and improvement within that. And both are important and both occur. But let's look at the history in the context of that. Now, I'm not going to delve too much into the details of history, but if you go back, obviously, in order to cure pancreas cancer now, we needed to do an operation. So Walter Kausch was not the first to do a pancreatic duodenectomy. The first one was probably done in Italy by accident by an orthopedic surgeon. That's a long story. Walter Kausch, though, was a surgeon who actually did both experimental, and he was a GI surgeon, and actually performed several pancreatic operations, never really published it. This is actually a good point to the residents. So it's not called the Kausch procedure unless you're in Heidelberg, then they call it the Kausch-Whipple. But pancreatic duodenectomy takes the name of this individual, Alan Oldfather Whipple. Now, why him? Because he certainly wasn't the first. He did the first probably in the 1920s. He reported a series of 3. But what he did is he published it and presented it at the American Surgical Association, and this took on his name. Now, I would say that although their intent was not to cure pancreas cancer, it was sort of developed for other reasons, that if you look back, this was revolutionary. We really never had an operation to deal with lesions in the head of the pancreas, and Trendelenburg was the first to do a distal pancreatectomy. So these operations, although not intended for pancreas cancer, was revolutionary. Now we go into a period of evolution. So Braunschweig at Chicago in 1937, actually, if you look at the original Whipple operation, it preserves much of the head of the pancreas. It doesn't resemble much what we do today. But Braunschweig moved it forward and made it a more oncologic operation for pancreas cancer, in which he did a near complete resection of the head of the pancreas. Now, vitamin K had not yet really been in wide use, and so it was still a two-staged operation because jaundice patients were coagulopathic. But after the advent of vitamin K, this operation started being done as a one-stage procedure. Alan Whipple presented a series of a one-stage operation. Ridgway Trimble at Hopkins presented a one-stage operation, and they were similar operations. Now the operation is beginning to look more like what we did. These were evolutionary changes, small tweaks to something that was a major change. Now, if you go to the 1970s and you look at the Whipple operation, the mortality was 25 to 30%, not disease-specific mortality, but dying from the operation, 1 out of 3. Nobody ever published on the quality of life. I can only imagine what these patients looked like. And really, we know very little about the disease-specific survival. We looked up the series at Hopkins, and there's really no long-term follow-up from the 1930s and 1940s. Never published it. We did it out of curiosity, but it was well less than 5%. Actually, Trimble published a paper specifically focusing on 11 patients with pancreatic cancer. We don't know the operative mortality. They probably only reported the patients that lived. And the longest survivor was 16 months. So you can imagine what the median survival was in this group. But he said something that was pretty profound in the discussion. And that was he recognized the unique biology of pancreas cancer. It's almost always metastatic. Well, that still stands today. It's a pretty profound statement. And there's an absence of early detection, still one of our major problems. There, at the time, was felt to be no good preoperative assessment of resectability. Remember, the CT scan was not yet invented. Patients were explored who were jaundiced, and the vast majority were found to be metastatic. Now, as I say, history repeats itself. I want you to remember these 3 factors. Now, I underline no good preoperative assessment of resectability because we have very good CT scans now, and we think we do a good job, but do we? And we'll get back to that. Now, because of this, at the time, George Cryle said, this is crazy. 30% of people are dying from the operation. There's really no long-term survival. You know, a bypass is probably better than doing a Whipple operation. And he argued against it, and appropriately so. You know, this is how science works. It's point and counterpoint, and he had a valid point. Then ushered in what Keith Lillimo calls the golden era of pancreatic surgery. John Cameron, Andy Warshaw, probably really the main leaders of this, but certainly Mary Brennan, a thought leader in this, really delved into pancreas cancer and into the operation itself. And a whole story in of itself, made some refinements, and here we are, you know, in the 1980s. Now, this paper was published later, but results from the 1980s, the mortality has gone from 30% to less than 1%. So now the operation can be done safely. Now, here's the bottom line. So this was revolutionary in that we moved the median survival. We now have 20% of the people, 1 out of 5, who actually make it to 5 years. This was not possible before. But you can see year after year, we haven't moved that needle at all. 20% survive, the other 80% die. I would say, though, that this is revolutionary. It's beginning to give us the tools that we need to get to the next level. Now, let's think about this, where we stand today. How do we fail in clinically localized pancreas cancer? This is a series published from our institution. We're not the first to publish this. It actually tells us something that we already know. If you take 500 highly annotated patients who underwent resection for pancreatic cancer and you look at their pattern of recurrence, about 80% die of metastatic disease. And remember, 5-year survival is 20%. So you can imagine what the rest are dying from. And this is a typical patient. This is an autopsy of a patient after who had a Whipple and had a recurrence, and you can see the extent of systemic disease. So clinically localized pancreatic cancer is not biologically localized. It is a systemic disease, and the best thing we have currently is local therapy. Okay? There's direct evidence of systemic disease. This is courtesy of Ralph Ruban, one of our pathologists. This is a early stage resectable cancer, and the green cells are the pancreas cancer invading into a blood vessel early and becoming systemic. This is when early stage pancreas cancer. Okay, now surgery alone is not enough in most patients, so systemic control is important. Now, I'm presenting a Conco trial. This is antiquated, it's outdated, but again, I'll get back to why this is important. But I think that this is an important and a landmark study for one reason. We couldn't do this nowadays. What was done here is patients were randomized from no chemotherapy to single agent gemcitabine. And although the survival improvement is modest, nonetheless, systemic control improves survival, and I'll say more about that. Now, we can discuss the here and now. Improved systemic control is important. We could debate neoadjuvant versus surgery first. Both have their merits. Both are important. It's not one size fits all. Optimal cytotoxic regimen, immunotherapy, targeted agents, that's all important, but I would say it's evolutionary and it's ongoing. Now let's switch gears a little bit. So this is a 3D CT scan of a patient that everyone here would love to see. Liver's clean, vessels are clean, and that patient is technically resectable. So that was the typical Whipple we did for years. And then this started coming along. So we started seeing isolated encasement of the portal vein, okay? And, there's no arterial involvement. There's a technical means to achieve a negative margin within something like this. There's a target above and target below. And a lot of these patients were receiving neoadjuvant at some institutions like MD Anderson, at others, like ours at the time, not so much. And here you can see such one of these typical patients. On a 3D recon, the artery's clean, the portal vein SMV is completely taken out. It's a pretty simple operation to do. You can see where the vessel's encased. This is an artery first approach. Divide the vessel and a simple end-to-end. So this became somewhat common, and we were sort of off to the races, but everybody was doing all different kinds of things when it came to this. And so a group got together and came up with a consensus based on what we call borderline resectable, meaning there was no distant disease and limited vessel involvement, or locally advanced and unresectable, which means no distant disease but technically unresectable, or is it technically unresectable? And that they decided that all of these patients should have neoadjuvant. Now, again, evolutionary changes, neoadjuvant migrated from one to the next with incremental changes. One of the things that came out in stage 4 patients was that multi-drug regimens such as FOLFIRINOX and Gemabraxane had much stronger biological activity against pancreas cancer, and sure enough, they were integrated into neoadjuvant and into adjuvant approaches with better outcomes. Again, not the main focus of this, but clearly the outcomes have been better, and it has changed the game. This is not the revolution, but it certainly has changed the game. How has it changed the game? Well, we have a situation like this. This is a series of 100 or so patients of ours who had either borderline or locally advanced. In this particular study, mainly were borderline resectable, meaning that these were sort of the traditionally resectable with minimal vessel involvement. And they underwent neoadjuvant therapy, aggressive. Most of them had SBRT, stereotactic body radiation. They either had FOLFIRINOX or Gemabraxane. And you can see that the overall survival in this cohort was greater than 60 months if they had a path complete response. Now, that had never happened before. We had no survival curves, even in node negative, where the overall survival was 60 months and median survival of 26 months. And this is true survival, not estimated survival. So improved systemic control results in a stronger impact in local control. So everybody recognized that, including places like UC Davis. And so he said, okay, better systemic control. The operation is becoming more aggressive. It actually begs the question of what exactly is resectable. Okay, so we all saw scenarios like this where patients, good performance status, underwent what would be technically called induction chemotherapy, really started out as palliative, and realized after a 6-month period they had no progression of disease. Okay, they had good performance status, but by the strictest definition, this would be considered unresectable. And then we asked ourselves, like, why is this unresectable, right? It's anatomy, not biology here. So we have an operation, and not us, we all have an operation that actually can deal with this. And one of the first reports was by Marty McCary, one of my co-fellows, and John Cameron, where they did this operation. I contend it was by accident, but they say it was by design, in which they resected the celiac trunk. See here, the celiac trunk is involved. They resected the celiac trunk and did something called an Appleby procedure. Now, we now in the modern terms call it a modified Appleby or a distal pancreatectomy celiac trunk resection. because the original Appleby procedure was for gastric cancer involving the lesser curve of the stomach into the celiac, and the stomach was removed. Now we preserve it. Again, sort of beyond the details of what's important. But in this operation, retrograde flow to the liver is dependent on the inferior pancreatic or duodenal, and it supplies the proper hepatic artery so that the common hepatic can be resected. This is an anatomic problem. This falls in the wheelhouse of surgery. It only makes sense to do if you have good biological control. Now, I can tell you at our institution, this is becoming a common operation. We probably do about one of these a week. You can see here what it looks like. The celiac trunk is resected. The end of the common hepatic artery is oversewn. The GDA is intact, supplying blood to the proper hepatic artery. And you can see that through collateral flow, retrograde, inferior pancreatic or duodenal to the GDA, the liver is supplied. Now, I want to focus on this area. If you look carefully, I left some tumor on that SMA, and I did that for a reason, not permanently, but just for this picture. Because one of the next things that we realized by doing these Appleby procedures, when you look at a CT scan and you see arterial encasement of the SMA, that was considered to be unresectable, okay? But as it turns out, as we started exploring some of these patients with the intent of getting them out, we realized something. We realized that this hunk of tumor here, first of all, is not contiguous with the primary tumor. We didn't cut through tumor to get to this. This is what looks like to be, to us, perineural invasion. And you can see that you can clean the SMA to a clean resection. There's no direct invasion of the SMA. This is a so-called arterial divestment, and that term was coined by Miao Yi in Guangzhou Hospital. You can see that there's a very dissectable plane. And people say, well, you know, because they're cutting through tumor. It's actually not. I mean, you can see it here. SMA is cleaned, and you can see this tumor, which is being removed, not contiguous with the primary tumor, but what this is really perineural invasion and lymphatic invasion, and we can see that under the microscope. It's not contiguous spread. And in a vast majority of SMA encasement, okay, you can do arterial divestment and achieve a clear margin. Now, if you have a string sign where the vessel is narrowed, it's not possible. That's very, very seldom the case. So again, that throws out this anatomic classification. It throws it out the window. We know that we can achieve negative margins in these patients and have a relatively stable rate of local control. So then what was the next step? And this is all evolutionary. Well, this was not the actual case, but an example of mine where I was doing this perineural divestment. And I actually got into the inferior pancreatic or duodenal artery, which supplies the gastroduodenal artery, and all of a sudden we had a problem on our hands. So what was the bailout procedure was to put a graft in. And this particular graft is cryopreserved iliac vein, which then restores flow to the liver. Well, that was sort of an accident, but we got to thinking, you know, why, if the GDA is involved, we say it's unresectable, but when the GDA is not involved, it's resectable. That's anatomy. That's not biology. That makes no sense, right? So, you know, we can deal with this. So then we started doing operations like this. So this wasn't, we just jumped in one day and decided to be crazy. This was a stepwise evolution. And now it's routine that the GDA no longer determines resectability. It's common. This is a common hepatic artery here, right at the junction of proper hepatic artery. It's common now for us to sew grafts in. This picture's a little bit antiquated. We now either use saphenous vein or, again, cryopreserved. But then the next thing is, well, if the common hepatic artery, you know, we can reconstruct, why would the proper hepatic artery get in the way? So we can, if the anatomy is favorable, we can take it all the way up to the right or left. Again, does this make sense? You know, people say, well, this is a little bit crazy, right? But the thing is, it's anatomy. And as surgeons, it's a wonderful time to be a pancreas surgeon because the operations are getting more aggressive because of systemic control. It's the anatomy here, and that's in our wheelhouse. The biology we'll talk about in a bit. Well, then we had a rule that we can't reconstruct the artery and do the portal vein because if they both go down, we're going to get liver ischemia. So until one day we didn't have a choice, and this again was not that case, but now we realized that the portal vein seldom goes down. We seldom lose flow through the GDA, and so now we routinely do a combination of arterial resections, reconstructions, and portal venous grafts. Now, back up again. Another operation that we used to do all the time was when the GDA was involved, while we're doing a Whipple operation, we would actually just do a little nip of that artery and then put the two things back together. Not much of a big deal. Didn't think much about it. But if you think about it, okay, well, we're reconstructing the hepatic artery, and we had done it to a larger extent before. Why should they even be limited to tumors of the body of the pancreas? What if the tumor involves the head, the body, the celiac trunk, and the hepatic artery? Okay? The next step in the evolution is, well, we just reconstruct it, right? So here's common hepatic artery. You can see that a Whipple operation was performed. A graft, again, cryopreserved. Now, we need to preserve the stomach. And so in order to preserve the stomach, we have to have flow to the stomach, which is only going to be through the short gastrics, because we've taken the left gastric, the right gastroepiploic, and the short gastrics are fed on the splenic artery. So we needed to reimplant splenic arteries, and we also needed to reconstruct the splenic vein. The splenic vein was involved, and you can see, again, a clean dissection and good local control. We preserve the pancreas. Some of the institutions that are doing this do total pancreatectomies, but we found no increased risk in pseudoaneurysms. So that's the arterial side. Now let's go to the venous side. So on the venous side, we said, well, if it's right in the middle, we have a technical operation for this, but it's still, at the end of the day, is simple plumbing. We need to get blood from the bowel back to the liver, and there's many different ways to do it. And we had patients like this, in which the SMV was completely occluded. Now, that's not really technically reconstructible using a standard technique. So we did something, what we used to call collateral preservation. We would actually do this operation and try to preserve all of the collaterals. You can see there's no SMA involvement here. And that worked really well until one day when it didn't work, when one of my partners called me to the operating room because they went a little bit too far and took too many collaterals. The vast majority of the small bowel looked fine, but the right side of the small bowel didn't. So what do? Well, we dusted off our old bag of tricks. Again, nothing new is really new. And we did what we call a mesocaval shunt. Okay. So then we get to thinking, why wait for a disaster to do a mesocaval shunt? Let's just start shunting these patients up front and make this operation much more enjoyable, where we don't have to worry about the venous return back to the liver. And so we now have incorporated these mesocaval shunts for unreconstructible SMV. In order to do this, you still need a certain amount of flow that goes through the left side, through the splenic vein to the portal vein, because the patient will become encephalopathic. But if you need to decompress a small portion of the small bowel, these mesocaval shunts work well. And you can see here the SMA completely skeletonized and this mesocaval shunt. Well, why a mesocaval shunt and not just tap it back into the portal vein? The issues are when you have decent flow and you're only decompressing one thing, anytime we clamp that portal vein, you put it at risk for further problems. And since the patients don't get encephalopathic, in cases like this, we would prefer to do that over reconstruction. However, we said, well, we do these reconstructions, and now we're limiting certain patients who don't have collaterals when we know we have the technical capability. Again, this is all good biology. We're not going on patients who don't have highly selected biology. Okay? So if you can sew in one graft, you can sew in multiple grafts. Here you see, again, SMV involvement with the completely occluded multiple collaterals. Here you see a skeletonized arterial divested SMA. And you can see a graft from the jejunal branch, the ileal branch and the jejunal branch. And here you can see what it looks like on the left side. By the way, these patients laying on their side here, you can see orientation. This is the same patient. You can see the SMA divested from the patient's left side. You can see the jejunal branch and the ileal branch. And these are sewed in with the bowel derotated the other way, so you're not standing on your head. And you can see this is sort of the femoral ligament of Treitz. And so we can bring this all the way around and pretty much reach any vessel that we need to reach to reconstruct. Sometimes we will combine venous reconstruction with mesocaval shunts. Now, if you told me a year ago that this patient was going to be resectable, I'd say there's no way. I mean, there's just nothing you can do to reconstruct this. And we noticed that we get in there and you attempt something like this where you attempt to do collateral preservation, and it's seldom when you have something to this extent, it does not work well. So we decided, why wait to get into trouble to do that? Why not find something that is free above, free below, and sew a shunt in before the specimen ever comes out? And now we have been able to resect patients like this, okay? This is one of those shunts. That's probably about a 20 centimeter shunt. You can see how it extends up behind the common hepatic. This is tapped into the left portal vein and the confluence is preserved, and it bypasses probably some unnamed branch below the SMV. This patient also had arterial encasement. You can see the divestment of the artery in which you have a clean artery. Okay, and it becomes a little bit like artwork. You don't know what you're going to bypass till you get in there and start clamping things and see where the flow, which way the flow goes, and what you need to get around. Here's an example of actually we were able to bypass from the mesocolon, which had anastomotic connections with the venous drainage of the small bowel, to the portal vein. So then we started putting everything together and even got a little more creative. So here's a patient who had involvement of the porta, common hepatic artery, SMV, portal vein, down to the base of the SMA encasement, highly select patient. What we did was we took the left gastric, and this patient actually had a bilateral involvement of both the right and left. We actually transposed the left gastric to the left hepatic. We actually took the celiac trunk and through a graft transposed it to the right hepatic. We had divested the SMA, and we used a left renal vein interposition on the portal vein. You can see that the area is completely skeletonized. We do believe in clearing what's called the Heidelberg triangle, and actually even taking it one step further, you can see high up into the hiatus where we do see local recurrences that we've cleared both the crura and the aorta is essentially skeletonized. Again, these things can be done in combination. Here's a similar case, portal vein reconstructed. This was a saphenous vein, hepatic artery reconstructed to the proper hepatic, splenic artery reimplanted. It was a long distance from the splenic vein. Again, you need venous drainage from the stomach, so we did another old technique called a splenorenal shunt, in this particular case using reversed saphenous vein. And I'll soon get to what the point of all of this is. So probably a lot of you are sitting here thinking, what are you guys doing? I know that the first time that I presented one of these at GI conference, Cameron goes, I'm going to call the police. And then my partner presented one, and he said, Jesus, I need to call the paddy wagon. But we've actually, got him on to the same page as us. And if you think about this, history repeats itself, okay? Because Dr. Cameron admits, back in the 1970s when he started doing Whipples for pancreas cancer, everybody said, you're crazy, what are you doing? The mortality is like 30%, this is ridiculous. Well, we know how that story ended, okay? And there's a lot of George Cryles out there, and there should be. There should be George Cryles, they're important, who argue against doing this. And it has to be considered, but we ask ourselves the question, why? Why would we do this, or why would we not do it? Well, first of all, remember this. I think that we all agree that surgical resection of localized pancreatic cancer provides the only chance of cure, and we can all agree that this is localized pancreas cancer, clinically localized. The first question we need to address is it safe? Well, these are unpublished data. Hopefully we'll get them published sometime soon. But it's a series of 800 patients with locally advanced disease in our clinic, 400 of whom met our criteria for evaluation for this study. We have some refined staging system, which quite frankly is meaningless, but LAPC 1 through 3 has to do with the vessels involved and stuff like that. The point being that we took a significant percentage of them to the operating room when we deemed them to be resectable. By the way, 90% of them turned out to be resectable, okay? So how do they look? Okay, now compare this to a contemporary series of straightforward Whipple operations. Well, our complication rate of Clavien 2 and 3 complications is about 50%. Well, I'll be honest with you, our complication rate in straightforward Whipples is 50%. The profile's not any different. We do see more chyle leaks in this group, okay? What is our 90-day mortality? Our 90-day mortality is 3%. Now, I'm not super proud of that. Our 90-day mortality for straightforward Whipples is 0.8. So we still have some work to do, but I think it's in reasonable and it's what is acceptable in the contemporary period for Whipple mortality. Our margin negativity rate is about 80%. And you can see something interesting. Because, not of the surgery, but because of the good chemotherapy, our pattern of recurrence is changing. Now the number one pattern of recurrence is local. It's in the wheelhouse of surgeons, okay? Now, I assure you, so this is a typical patient. Just like fishermen, surgeons don't lie. So, in all seriousness, this is somebody post-op day 5 after one of those operations. They don't all look like this, trust me. But the majority look like they're in pretty good shape, just like any other Whipple. Now, the next question we have to answer, though, is, okay, well, I think that you'll agree it's safe. Is it effective? Okay. Well, if you look at the survival curves for this, now it's retrospective. This is not a randomized study, but we did our best to match them to patients who we ended up not taking. Now, clearly, we didn't take them for a reason. A lot of it had nothing to do with their performance status, but more with their anatomy. And you can see that there is a huge survival benefit in patients who underwent resection. In the most severe cases, sort of the ones that I showed you, believe me, I didn't show the easy ones, the median survival is 30 months, okay? Better than what we do in our surgery first, small tumors, and it's not even reached yet in the earlier ones. So if you ask the question, what's resectable, I would say that almost anything. We have a patient we're considering putting in a Caselli graft and reconstructing the SMA, hepatic artery, everything, portal vein, and I think it's going to be reasonable. So this sets the stage for what I want to close with, which is what I really think is the next revolution. And it's not only going on. These kind of things that I present are going on at any high-volume institution. And the next revolution is underway by people like Sepeda or people who don't even know that what the next revolution, and may not be thinking about it in this way. And I'll explain what I mean. Now let's go back to this figure. We pat ourselves in the back, 60% or a 60-month median survival in this cohort. Well, that's all well and good if you get lucky, right? You get lucky, it was luck. We treated them all the same, and it was completely random. About 10% got lucky and had this great survival. What we need to do is change from lucky and random to targeted and intentional. Okay, and let me tell you what I mean. This is the kind of patient that you guys probably don't see it. We don't see it anymore. I had to work to find this slide. This is a patient with the easiest technically resectable tumor, okay? Something now that we would do robotically. They underwent an uncomplicated Whipple operation and received adjuvant therapy, or were about to receive adjuvant therapy, and this is their CT scan at 3 months. Riddled with pulmonary disease, riddled with liver disease, carcinomatosis, and ascites. Now, I would submit to you that that patient, based on the criteria, is clearly resectable anatomically, but biologically unresectable. Now, here's another patient. I don't have to go through the details. It's wrapped around every blood vessel, okay? And this patient underwent an uncomplicated, I believe this was Jin's patient, underwent an Appleby procedure at 4 years NED. I would argue that by the strict criteria, this patient is not resectable, but is biologically resectable. They benefited from this operation, unlike the first patient. So we need to switch gears and change from anatomy to tumor biology, and change the question from what can we resect, because we can pretty much resect anything, to what should we resect. So what we need is precision. Now, I didn't include, this is my uncle. I'm a hillbilly from the Appalachians, and this is truly my uncle. And I put this, it was not a random picture. I put it in for 2 reasons. My uncle still doesn't realize that the American Revolution ended, and he's still here protecting his farm. So it goes along the topic of this conversation, but the second thing is he's shooting a 200-year-old long rifle that is a flintlock, okay? Antiquated, or, really nothing revolutionary here with that rifle, but he can hit a quarter at about 100 yards, so it can be effective. Now, why do I put that in here? I would submit to you that the tools that we have today actually can move the needle. You hear about targeted therapy going after KRAS and all, important, highly important. Those things need to be done. But if we had predictive biomarkers to guide therapy, we could use the exact tools that we have today, which some might even call antiquated, to improve the outcome. And now how we're going to do that? Well, we need to do molecular staging. We need to measure biology, and these things are all within a capability. We need real-time feedback on how we're doing with treatment, almost like a CBC for cancer. We need to be able to measure this response to therapy, and we need to measure clonal evolution. So these are just a few examples, but they're not exhaustive. I know that there's work being done here. This is a simple test for circulating DNA, and we developed it. It's nothing. Bert Vogelstein developed some of the circulating free DNA tests. This was something that we took simply just to look at KRAS. We did something called digital droplet PCR and made it a CLIA-approved test. You can now order it on Epic. Okay, big deal. Well, here's the big deal about it. It actually already stratifies patients just based in a small prospective study that we can already predict what's going to happen long before it happens. In fact, it predicts things a median of 80 days, several months before it happens. I'll get back to why this may be important. Okay, but ctDNA alone, circulating tumor DNA alone, is not the end-all be-all. Okay, that's just one of the tools that we potentially have available. We know tumors secrete circulating tumor cells. They give rise to disseminated disease, micrometastatic disease, which is, I would say, what we need to focus on as surgeons. It's what we leave behind, not what we take out, that's important. And this is what gives us our failures. So our group has presented that even in early stage patients, that over 90% have circulating tumor cells, and not all circulating tumor cells are the same. There's a subset of transitional cells, transitional between epithelial and mesenchymal. Why is this important? Well, their biology changes very differently. So these cells have the ability, potentially, we don't have direct proof of this yet, but we're obviously working on it, to set up metastatic lesions. They survive in circulation. They're actually free of undergoing anoicus when they go through this transition. They can survive the harsh conditions. They probably travel as clusters. They probably travel with some of their supporting cells, such as stromal cells. Okay, and that's interesting, and that's a whole other topic, but they're also very good biomarkers, and here's an example. This is work we presented at the American 2 years ago. And this just gives on, because I'm sort of simplistic, and sometimes the stuff gets lost in the statistics, but this is an individual patient. You can see that their circulating tumor cells dropped, and in particular the mesenchymal cells dropped. They dropped further after adjuvant therapy. Now, when we saw this patient back, they were disease-free at 254 days, and they had a slight rise, but this rise, based on the calculation, didn't predict recurrence. When we saw them back at the next follow-up, they were looking even better. They were recovered from the operation, high-level CT scan, tumor marker was normal, everything looked fine, but the CTCs predicted a response, and then at 472 days, it predicts response. Now, we can predict response with circulating tumor cells at least 2 months. It's probably not the most accurate because these studies were not designed to actually measure things, accurately in the lead time, but I would say that probably at least by 2 months we can predict recurrence. It also gives us information on clonal evolution. You can see that there's many more mesenchymal cells, so when it recurs with a vengeance. Okay, it predicts response to adjuvant. You can see if you do respond, you do better. If you don't respond, you do worse. Now, how can we integrate this, and why is this important? And I'll close with the last few slides here. Well, this is a particular patient that you could say, well, what if? This is a patient who was diagnosed with pancreatic cancer, borderline resectable. They went on FOLFIRINOX treatment, and we have every patient we see is pretty much in the context of a clinical trial. They were also on GVAX, Listeria, Novolimumab, which is just as a clinical trial, probably irrelevant. But they went on neoadjuvant therapy, and before we ever got them to surgery, they progressed to metastatic disease. Now, what if we had that marker, and on 1 week we knew that they're not responding at all to the FOLFIRINOX, but they potentially may respond to the Gem/Abraxane, and we switched into Gem/Abraxane? Would have the response been different? We don't know. It's something that we have to study, but we do know this, that a lot of people who don't respond to FOLFIRINOX will respond to Gem-Abraxane and vice versa. We just find out too late. Here's the other thing about important about circulating tumor cells. As a surgeon, in a single day, you think about pancreas cancer being a systemic disease. There's a solid and a liquid population, and in a single day, we go from trillions of cells to probably about 50,000 cells, and we have only the liquid population. And the tumor that's sitting in the bucket in pathology is not what's going to recur. It's what we leave behind. And this biology is not the same as the primary tumor. Tumor microenvironment's different, the metabolism's different, they probably don't express MHC1 and evade the immune system. They have much more like stem cell features as a proportion. We even have demonstrated that they have stem cell-like expression pattern. They still haven't been able to culture them, but we think that these will be the ones that we will be able to ultimately. The interesting thing is that these are patients who haven't recurred at 1 year. They still have these cells circulating. Now we know that the half-life of a circulating tumor cell is 15 minutes. So these are coming from somewhere, and they're a window into the micrometastatic disease, the reason that we fail. Okay? And where's this going? So with looking at this, we now can sequence these cells. It doesn't give us much information other than they're tumor-derived. We can do expression profiling on these cells, which is actually, I think, going to prove useful in that we can now categorize and predict response, potentially. And we're getting close to the point where we can culture these cells and hopefully do pharmacotyping, not to assess the responsiveness of the primary tumor, but what we leave behind. This is my last data slide, and I want to get back to this Conco trial, okay? Why do I say that we have the tools that are here and now? Well, the median survival here by gemcitabine is minimal, right? But let's look at this in another way. This is a prospective trial. If you take 100 people, 6 of them were cured with the operation alone. If we could predict that with biomarkers, they would just need an operation and that's it. We say gemcitabine is a terrible chemotherapy, but for the 8 patients who had surgery with the addition of gemcitabine, it was a miracle drug. It cured them, okay? Now remember what I said, well, we have responders to FOLFIRINOX, we don't know, but what if we could do something for these other 80%? So for example, what if we knew the 25 up front who were going to respond to FOLFIRINOX and be these exceptional responders, and that's what we gave them, and eliminated all of the other stuff. We went from random to targeted. What about the 20% that are going to respond to Gem-Abraxane? How about targeted therapy such as BRCA-specific PARP inhibitor? I mean, you name it. There's about 15% of pancreas cancers are targetable, and there's probably a percent that we just can't do anything about. We would ultimately move that survival curve, right? And I do think that this is going to be the next revolution, and it's actually here now, and the work is ongoing, and we don't need new targeted agents. It just is integrating effective systemic therapy, which we have available, in a non-random way with good surgical care. So to conclude, systemic control is a major limitation to cure patients with localized pancreas cancer. Surgical care of pancreas cancer has undergone a series of evolutions and revolutions, and there's been improvements. But I think that the next revolution is not so much going to be in the operation. We're evolving in that operation, but it's going to be applying what we already have in a non-random fashion so that we're not playing the percentages, so that we are treating people based on their tumor biology. And this is only through biomarker guided therapy. So once again, it is an honor to be here, and I really appreciate your attention. It's an honor to present this on behalf of my group. Jun Yu is one of our basic scientists. Marty McCary is a pancreatic surgeon who now is so busy with research, doesn't operate very much anymore. John Cameron still comes in 7 days a week. The operative group who did those operations that you saw is Kelly LaFaro, our newest member out of City of Hope, Jin He, Rick Burkhart, and Will Burns. So thank you once again.
I have to say, what a spectacular presentation and really a great illustration of how many of the principles of one branch of surgery can influence another branch of surgery. I mean, I was thinking way back to all the operations that we did for cirrhotics, portal hypertension.
Yeah.
All those shunts came from that.
Yeah.
All of the vascular surgical
Mm-hmm.
principles, all the transplant overlap.
Yep.
And you don't know
Right.
what it was that you got from one other
Yeah.
part of your surgical
Absolutely.
training that influenced
I mean, the
other.
interesting thing is, like I said, nothing, I think there's really, in my mind, maybe it's just me, there's no good idea that hasn't been done already. So Fortner at Memorial used to do stuff like this, but he was ahead of his time because there was no good systemic therapy. Now we're doing the exact same thing he did, but better outcomes, not because of better technique, but just because different times and different therapies. So
It's really true. I really want to thank you.
Thank you so
We
much.
want to present you with our little, speaking of a little molecular medicine,
Nice.
our little DNA that hangs in our building.
That's
is what
great.
That's for.
well, thank you
Okay.
so much.
Quick picture. We'll get some more at the end, but I want to just take a minute for questions. There's a lot of, you raised so many issues about, how to sort of target our precision medicine to what is also, the biggest operation. So it's an interesting combination of those two. Any particular, Dr. Goodnight?
As an old boy, Chris, I might react like John Cameron, although I think obviously your team is very dedicated, very careful. You all need strong cardiologists. Your operations here are a study in visceral anatomy, if we need to take the medical students and so forth. But think about these very, very complex operations, and to make progress, it has to be done so carefully and so well done as your dedicated team does. How would you like to see this expanded? I mean, the chance of these very complex operations in the wrong hands giving what you're trying to do basically a bad name as it expands. And
Yeah, I think that, it's institutions like UC Davis, like Hopkins, where I think that these things will be promulgated. I'm sure the conversation was very similar, and actually it was very similar back in the 1970s when they were doing the Whipple operation. I mean, that was, the Birkmeyer publication, when these operations are done at low volume centers, the outcomes are much worse. Hopefully we've learned from that lesson, but this is nothing magical. These techniques can be done anywhere, and I think that it just, as we train the next generation of surgeons how to do them, and I'm sort of Cameron-centric just because I'm influenced by him, but if you look at what he did is when they established the high-volume centers, right, at the time his understudies were Lilimo, Yo, Henry Pitt, and those, and he basically sent them out, who then started centers, and if you look at a lot of the high-volume pancreas centers, you can trace your lineage back to Howard Reber, Andy Warshaw, John Cameron, Murray Brennan, and now the Whipple operation is, standard technique. And I hope that minus the mistake of doing it in low-volume centers, that's how it's promulgated here. But I don't think it is going to change in the next 5 years, but maybe 10 years. And hopefully at the same time, the tools fall in place to do precision approaches in selecting patients.
I was struck with some of the thinking that happens around breast cancer surgery now, where the oncologic surgeon is responsible for the extirpative part of the operation,
Yeah.
and perhaps you have another team who comes in to do the reconstructive part of the operation.
Mm-hmm.
And I was thinking of, other, should we be leaving part of that pancreas or not, where there's just lots of
Yeah.
other approaches to
Well,
cancer that made me think.
Yeah, actually, well, you had pointed, it was at the end of M&M, you had concluded by saying phone a friend and make sure. We actually have a very close-knit group, and it's not a pride thing. In fact, we do it up front, and this is not like this is case after case every day. I mean, this is, maybe 20% of the cases that we do are like this. But we load the boat right from the start. It's like, Rick, I'm going to be doing this case next week. Look at this film. This is what I'm going to do. And some of these, so I had a good bit of vascular training, but in the beginning when we did some of these things, we had the vascular surgeons involved, and because ultimately it's about the patient outcomes, and and why not involve vascular? Now, you get to the point where you do so many vasculars, like, well, enough's enough, right? You got it. So you're absolutely right. It is a team approach, and it's nice having a group of partners who there's no shame, or just we call each other in, and things go smoothly. It's very enjoyable, and it's actually it's a really exciting time to be a surgeon.
Well, thank you again. Really appreciate your coming.